Welcome, everyone. For today's Better Breathing Institute webinar, I am joined by Jessica DeMars. Jessica is an experienced Radcliffe breathing method trained physiotherapist and leader in the area of breathing rehabilitation. Jessica's practice has evolved from treating individuals with chronic disease and understanding the behavioural aspects of dysfunctional breathing to becoming an advocate for people with long COVID. Jessica has been invited to speak at conferences around the world about inspiratory muscle training, breathing pattern disorder, asthma, COPD, long COVID, breathing in performance, and breathing for voice. Jessica has also engaged in looking into the research and relationship between the diaphragm and pelvic floor muscle function, which is the topic for today's presentation. So it is my pleasure to welcome Jessica to talk to us today on this emerging area of research. And there will be an opportunity for questions at the end of this presentation. Thank you, Jessica.
Thank you, Sabrina, for that introduction. Yeah, I'm just going to provide kind of a high-level overview of kind of the relationship between breathing and the pelvic floor, what the evidence has showed us about that, and how things can break down, and then the little bit of evidence that's emerging on using various breathing techniques to engage the pelvic floor. So I'll get the technology out of the way here. We'll share. And I'll just pop it into presentation mode. Great. So yeah, again, so the objectives really is to just kind of explore the relationship of breathing and the pelvic floor muscle function. We're going to review some of the evidence behind various breathing techniques and their effect on pelvic floor muscle function, and then hopefully have a little bit of a conversation time at the end to discuss maybe some future directions. I have some ideas about it, and while I have done like a teensy tiny little bit of investigating into this area, and of course involve pelvic floor work with a lot of the rehabilitation that I do, certainly be keen if there's any experts in the room that have some ideas about it as well. Okay, so first of all, let's talk about that functional relationship of the diaphragm and the pelvic floor muscles. So how did we get here? How did we get to be talking about these two, which, you know, on the outset might seem unrelated muscles? So early on, way back in 1997, Paul Hodges, is a physio out of Australia, was looking at the role of the diaphragm in postural stability. So basically, they were looking at the response of the diaphragm to different postural perturbation produced by rapid flexion of the shoulder. So if you were standing and flexing your arm, what was going on with some of the other muscles? So they had actually an EMG activity into the diaphragm. And what they found was that there was an activation of the diaphragm just prior to the onset of the deltoid shoulder muscle. So this kind of anticipatory contraction occurred irrespective of the phase of respiration that you were in. So it doesn't matter whether you're breathing in or out, we would see this little activation of the diaphragm. So basically it was contracting in anticipation of postural adjustments required when you move your arm back and forth. So this started the discussion of how maybe the diaphragm has a role in postural stability. Then they kind of expanded on that study in 2000, and they were kind of basically showing that yes, there's some phasic movement of the diaphragm during breathing, but again, we're repeating the fact that it can that we're now seeing there's this contraction of the diaphragm that has nothing really to do with breathing, but more to do with that arm movement. So there's diaphragm activation at both respiratory frequency and movement frequency. Again, just kind of saying, hey, that this muscle is involved in more than just breathing. And then this starts to expand into looking at the pelvic floor muscles. Well, what are the pelvic floor muscles doing during these similar tasks, right? So now we've got EMG activity of the pelvic floor muscles during those arm movements as well as during breathing tasks. So again, what they were able to demonstrate is, like the diaphragm, the pelvic floor muscles, so that's PFM, we're going to use that a lot here, the activation was increased in advance of those arm movements, and that there was some kind of phasic respiratory activity of the pelvic floor muscles, and it was primarily expiratory. So just to kind of highlight this. This is kind of a schematic representation of what that shows, is that under normal physiological conditions, we have these stabilizing muscles. We kind of always knew about the abdominal muscles. We always knew about the back muscles, but now we're involving the diaphragm and the pelvic floor that activate prior to doing some sort of purposeful movement. And then we start taking kind of some deeper dives, looking at the diaphragm and pelvic floor motion in this study from 2015. This involved 20 healthy female students. And what they found was that during deep or maximal inhalation of the diaphragm, it would move down about 6 centimeters. But when you engaged the pelvic floor muscles, there was a decrease. So basically, the activation of those pelvic floor muscles influenced what the diaphragm was then able to do. They also measured pulmonary function, and from the study, it appears as though they had that pelvic floor motion contracted through all of the maneuvers. So whether they were breathing in or breathing out, they had that contraction of the pelvic floor muscles. And what happened was there was actually a decrease in FEV1, and the suggestion was that this was likely due to the contraction of the pelvic floor muscles. And that resulted in an increase of intra-abdominal pressure, and that reduced the limitation, and that resulted in the limitation of inhalation. So we'll kind of talk about the relationship between those muscles in just a second. But basically, what we're seeing is that activation of the pelvic floor can change the behavior of the diaphragm. We kind of continue on this track, and we see that these studies are showing, yep, there's more pelvic floor activation before and during a cough, and that's going to come into account later when we talk about some of our respiratory diseases, especially those that have a lot of cough. And that when there is an increase in intra-abdominal pressure, like doing a Valsalva or bearing down, that there's going to be more pelvic floor activation. And then in 2019, there was a little bit like a much more of a deeper dive, kind of looking at the activation of the deep and superficial pelvic floor muscles during a range of respiratory tasks in different postures. So what they had was 12 women without pelvic floor dysfunction participating in this study, and there was basically a surface EMG electrode was used to record the activation of the superficial and deep pelvic floor muscles during quiet breathing, breathing with increased dead space, so kind of breathing quickly, coughing, and maximal and submaximal inspiratory and expiratory efforts. So as breathing demand increased, the deep layers of the pelvic floor muscles had greater coherence with the breathing, but then during cough, it was a little bit more of the superficial pelvic floor muscle. So again, just kind of showing the intricacies of how this whole system works together, how these muscles work together. So if we look at what we kind of are talking about now is this kind of idea of the cylinder. Okay, so we're looking at how do these muscles work together. So we've got the diaphragm kind of at the top of this cylinder. We've got the pelvic floor supporting the bottom of it. And then we've got deep abdominal muscles in the front and deep muscles in the back. Kind of, and their role is to manage intra-abdominal pressures. Okay, so as we're breathing, as we're moving, there's going to be a change in the pressure inside our abdomen. Let's kind of think of it as a balloon or a water balloon in there, squishing on different sides. How is that going to change things? So this is this kind of 2022 review's objective was to propose a basic concept for the influence of different breathing patterns on pelvic floor during strenuous physical activities. So they reviewed recent literature, basic knowledge of classical Western medicine regarding the principles of muscle physiology, biomechanics of breathing, and then also used magnetic resonance imaging, so MRI data, to corroborate the proposed concept. So basically what you're looking at in this diagram is under normal conditions, okay? We breathe in, and the diaphragm, so the muscle at the top there, labeled D, is going to go down into the abdominal cavity, When we don't have any kind of stressors or anything else going on, the pelvic floor muscles and the deep abdominal muscles, which is the two gray arrows, so deep abdominal DAM and PF pelvic floor muscles, are going to essentially relax and allow for kind of a distension in the abdomen and pelvis to keep the intra-abdominal pressure the same. So we don't need to be increasing the pressure in our abdomen every time that we're breathing. And then when we breathe out, there's kind of a recoil, the diaphragm goes back up, and the pelvic floor muscles and the deep abdominal muscles will have kind of almost a little bit of a contraction. There's not a lot of activity in those muscles with just restful breathing, but there will be a little bit. So again, kind of everything's kind of working to maintain the same pressures in the system. Okay. And then everything is working well together. We'll have that increase. So as we increase our load, so as we're lifting something, what we'll start to see is that there's an increase in the pelvic floor muscle activity, the deep abdominal muscles, the superficial abdominal muscles. And that's when we have that open glottis. So our throat is open, we're not breath holding. Okay, so that's why we kind of encourage people, you want to breathe as you're lifting something so that we're not really increasing that intra-abdominal pressure too much. So we kind of have this coordinated effort. Now, eventually, a load is going to be really high, or we're going to strain a little bit and close our throat or close our glottis. What's going to happen is you will have an increase in intra-abdominal pressure. More force is exerted on the pelvic floor muscles, and in good health, we would have those muscles be strong and supportive. Sometimes what happens though is we see that the pelvic floor muscles are not able to manage the load, and that's usually where we get it into dysfunction. Okay? So we just kind of want to think about that relationship between the diaphragm and the pelvic floor and how we want to have those muscles working in a coordinated fashion. And it does change depending on our load and also posture. So all of this is kind of like when we're talking about that up and down motion and coordination under those lower loads in upright postures. Okay. So this one just kind of demonstrates what happens if the load ends up being too great, right? So we don't have that support through the lower abdominals, through the pelvic floor. And what happens is that as we breathe in, the diaphragm comes down and we're getting the force is too great and the pelvic floor is not going in the right direction. So we breathe in, it goes down, we breathe out, maybe we hold our breath, we strain, we close our glottis, and we start to lose pressure kind of and contraction through through the pelvic floor. And that's essentially when we can look at, we'll find things like urinary incontinence will happen in those situations. Okay, so again, we want to be able to have the ability to have strength through the pelvic floor. It's going to support the movement of the diaphragm. We want to have the diaphragm moving. That's going to help the function of the pelvic floor. Okay, so let's take a look at some of the studies that are out there. I tried to look at, kind of grab some of a little bit more of the newer studies that kind of look at just kind of this relationship and when things go wrong. So this is the impact of urinary incontinence on physical function and respiratory muscle strength in incontinent women. So this is a 2022 study. SUI is stress urinary incontinence. And so what we've got is we've got 31 women aged 35 to 36 with stress urinary incontinence matched against 29 healthy age-matched controls. The measurements are, they're looking at the urinary dysfunction index, 1 hour pad test, and then we're also looking at respiratory measures. So MIP, maximum inspiratory pressure, MEP, maximum expiratory pressure. Physical function was the timed up and go test, and then abdominal muscle strength. And basically, what they found was that expiratory muscle weakness was actually linked with stress urinary incontinence and poor physical function. So they had weaker abdominal muscles, poor results on the timed up and go, and there also was increased waist circumference as well in these individuals. So again, starting to see this relationship of, hey, when the respiratory muscles are weaker, that can be one of areas of that whole canister system or that cylinder system. If we've got one area breaking down, it can lead to breakdown potentially in other areas. So this is another 2022 study, and they're using ultrasound to measure the thickness of the external obliques, internal obliques, transverse abdominis, so that deep abdominal muscle, diaphragm thickening, diaphragm excursion, so the motion of the diaphragm, as well as pelvic floor muscle contraction. So in this one, this is non-specific low back pain. So we're looking at 23 individuals with low back pain matched against 31 controls. And basically what they're looking at, so the diaphragm thickening fraction is the difference between the thickness at the end of inspiration of the diaphragm. Okay, so as you breathe in, the diaphragm thickens. And then as you breathe out, it goes back to its returning state, so it thins. So the diaphragm thickening fraction is the difference between thickness at the end of inspiration minus the thickness at the end of expiration, and that number is then divided by the thickness at end expiration. So based on the results of this study, it seems that subjects with low back pain present with a lower thickness in their external oblique muscles at rest. They have lower pelvic floor excursion when performing a voluntary contraction of the pelvic floor muscle, so it's not moving as well. There's lower diaphragm muscle thickness during inspiration. There's lower diaphragm thickening fraction, so it's not, arguably it's not thickening as much as we'd like to see, so maybe there's some weakness there. Just checking my notes here. But they do not present with lower thickness of the abdominal muscles compared to healthy subjects. So again, we're seeing that there's problems with the diaphragm, pelvic floor, and some of the oblique muscles. So in addition, there's a correlation between the pelvic floor like excursion and the diaphragm thickness in both inspiration and expiration. And there was a correlation between the resting external obliques thickness and the thoracic diaphragm thickness. Okay, so we're seeing that there's these differences that are occurring kind of again within that cylinder. So we're seeing problems with some areas that can be then impacting other areas. Yeah, this is a 2021 study looking at the relationship between symptomatic pelvic organ prolapse and respiratory muscle strength in middle-aged and older women. So we had 204 women from northeastern Brazil in this study. They used a structured questionnaire to look at a few demographics and their history and symptoms of pelvic organ prolapse. And then they measured their maximum inspiratory pressure and maximum expiratory pressure. And what they found was that symptomatic pelvic organ prolapse is associated with lower respiratory muscle strength. And basically, this is a really neat study to look over. And one of their interesting comments in the end with their conclusion, that there was kind of this idea that we need to look at the integrity of the pelvic floor muscles when also assessing respiratory muscle strength. So starting to see the impact perhaps of pelvic floor muscles on respiratory muscle strength as well. Again, so looking at either sides of that canister, if one is dysfunctional, perhaps we need to be thinking that the other side is also having an issue as a result of it. This was a study that investigated the relationship between urinary incontinence and respiratory muscle function in middle-aged and older Japanese men. And so basically, they uh, 700 community dwelling men aged 40 years or above were recruited from community centers and hospital outpatient clinics. International Consultation on Incontinence Questionnaire short form was administered to decide on their urinary incontinence status. And then standardized spirometry was performed. And so that what they found out of all of the individuals that responded is that 7.6% of them had urinary incontinence, and all of those individuals had significantly lower FEV1 and FVC. So we're seeing, again, that impact potentially on the dysfunctional pelvic floor, weakness in the pelvic floor leading to a urinary incontinence. It's also affecting respiratory function. Okay, this was a 2024 study looking at, again, just the association of pelvic floor dysfunction with chronic respiratory diseases. And basically, if we're looking at this here, we can see that most individuals with respiratory disease, this was for ages 35 to 50 years, we're reporting either moderate or severe bladder dysfunction. There was also a fairly high percentage having bowel dysfunction as well. Okay, so again, just this reiterating this relationship of how we can have a problem with one area affecting the problems affecting the other. So maybe before we weren't thinking about impact of respiratory disease on pelvic floor or the impact of pelvic floor dysfunction on respiratory function, but we're starting to see all of these studies that are kind of leading us towards, hey, this is something that we maybe need to be thinking about. Came across a few newer studies. So this is a 2026 study that's looking at the ultrasound measurements of the pelvic floor and diaphragm muscles in chronic obstructive pulmonary disease patients with urinary incontinence. So that's the UI. Basically, they measured the pelvic floor muscle contraction and diaphragm thickness with ultrasound. Pelvic floor muscle contraction severity and diaphragm thickening fraction index were found to be lower in COPD patients with urinary incontinence compared to COPD patients without urinary incontinence. So again, we're seeing that relationship, right? Starting to make us think, hey, we should be checking out pelvic floor function with our respiratory patients. Okay, this is another 2026 study. So there's some brand new studies that are out there. This is the assessment of abdominal diaphragm and pelvic floor muscle function during respiratory tasks, again, using ultrasound. And this is in women with and without postpartum stress urinary incontinence. So we had 162 women in this study, comparing 54 women with postpartum stress urinary incontinence with 54 postpartum continent women, and then 54 women who hadn't had any children. So they were looking at the pelvic floor muscle activity, diaphragm excursion and thickness, abdominal muscle activity, and this was assessed at rest during maximum deep respiration and cough. And once again, we're seeing that women with postpartum stress urinary incontinence had reduced thickness of the abdominal muscles, limited diaphragm excursion, and increased pelvic floor muscle activation. So again, we're seeing that relationship is being disruptive. So their conclusion, of course, was that effective postpartum rehabilitation may benefit from addressing the coordination of the diaphragm, the abdominal wall, and the pelvic floor muscles during breathing, rather than focusing solely on pelvic floor strengthening. So this is where we're really starting to get into that kind of narrative of, hey, let's be looking at all of the things involved with this system. It's not just pelvic floor muscle strengthening in isolation. Maybe we need to start bringing in a little bit more breathing to the mix. So let's then take a look at the studies that are looking at adding breathing exercises to pelvic floor muscle function. So start off with the first study that I came across was, can you breathe yourself to a better pelvic floor? And so this was a systematic review published in 2023. They used 18 studies and all of their criteria there. The conclusion from these studies was that the evidence for incorporating breathing exercise in clinical practice is scant or non-existing. Now, I went through and looked at the studies included in this review, and I was a little bit confused as to how it fit in with the title of the article. Most of the studies that they were looking at was about a technique called the hypopressive technique, which I would argue isn't really a breathing technique because it's not a normal function of the diaphragm. Basically, what you do is you are kind of sucking in your abdomen and kind of trying to lift up your diaphragm while you're not breathing. So in my opinion, clinically, it's not necessarily the normal function of the diaphragm. So I'm not sure if we should be including that. You're not literally breathing at that point in time. There's a breath hold and a kind of a suck in motion with it. So again, most of the studies were looking at that. They were critiquing studies that were observing pelvic floor motion during different breathing tasks, as well as things like coughing. So it wasn't necessarily that they were looking at the rehabilitative effects of various breathing techniques on the pelvic floor. So I didn't find that this was the best systematic review. I felt like it was a little bit biased actually from the start in what they were looking at. And that can be true of any systematic review. So what I did is I took a look at some of the studies that are a little bit more recent since that review was done. And so we'll take a dive into some of these. So this is a 2026 study. So a nice new study looking at the effectiveness of diaphragmatic breathing exercises added to pelvic floor muscle training individuals with urinary incontinence. And so basically we had 33 individuals assigned to just pelvic floor muscle training exercises. And this was the Kegels, okay? So activating the pelvic floor, and it was 3 days per week that they were doing them, 2 sets of 20 reps. And then they had 33 in the intervention group, and they were doing the same thing, but they also had a deep breathing exercise. Now, the deep breathing exercise was that they were going to lie down on their back with their hands on their lower abdomen. They took a fairly deep breath over 10 seconds and then exhaled without engaging the pelvic floor muscles. They did this 2 sets of 10 minutes of this deep breathing for 3 times a week. So what they found was there was improvements in incontinence severity, incontinence-related life quality of life, and symptom severity in both groups. However, the integration of deep breathing exercises with pelvic floor muscle training did not produce significantly better outcomes compared to pelvic floor muscle training alone. My only critique of the study would be that it's somewhat of a weak breathing exercise, I would say. We're not really doing much more than just engaging the diaphragm, and there was no coordination of the diaphragm motion with the pelvic floor. So it was like you'll do your breathing over here, which is totally separate, and then you'll do your pelvic floor muscle training, which is totally separate. And what we've kind of highlighted here is actually these muscles work together. So I'd argue that we should be looking more at coordinating pelvic floor muscles with the breathing to get a little bit better result. That's just my own personal bias. Okay, so next study, this is a 2024 study that came out of Turkey that compared 2 different types of diaphragmatic breathing added to pelvic floor muscle exercise. So what they did was they used this ohm-tracked biofeedback device. So it was basically a band that went around the abdomen that provided biofeedback to breathing for this intervention group. So we had 37 individuals doing what they called standard diaphragm breathing and pelvic floor muscle exercise. So I think it's just diaphragmatic breathing. And then in the intervention group, they used this biofeedback, which encouraged what they said was 360 degrees expanded diaphragm breathing. So the instructions were to breathe for about 15 minutes and then do pelvic floor exercises for about 20 minutes, 2 days per week. And so their primary outcome was the pre-contraction of the pelvic floor muscles under load. And then secondary outcomes were things like urinary symptoms, pelvic floor, and respiratory functions. Both groups improved kind of equally on those secondary outcomes. In the intervention group, the time to initiate a contraction of the pelvic floor muscles during a Valsalva was shorter, meaning that they could activate those muscles quickly when they were faced with the load that would happen in a Valsalva or, say, a cough. So, a little bit benefit there to having a little bit more in-depth breathing exercise. My personal view on this one is that 2 times a week is not really enough training. We're not creating that functional breathing strategy where we're really incorporating the breathing and the pelvic floor function together. Because once again, it was do your breathing over here, do your pelvic floor muscle exercise over here. So again, I'd like to see a little bit more working together. Okay. So here's one out of from 2024. So looking at the effects of inspiratory muscle training on stress urinary incontinence in North African women. And this was a randomized controlled trial. So we have 27 incontinent women were randomly assigned to either inspiratory muscle training, IMT, or sham IMT, performed over 12 weeks. And they were to do 5 sets of 5 breaths 3 times per week. Their main outcomes were the urogenital distress inventory, the IIQ, which is the Incontinence Impact Questionnaire, the 1-hour pad test, pelvic floor muscle strength and endurance. They did maximum inspiratory and expiratory pressures. They did the timed up and go and a 6-minute walk test. So really comprehensive program. And the results showed that for those doing IMT, they significantly reduced the severity of their stress urinary incontinence. They improved their pelvic floor muscle function, enhanced physical function, and increased respiratory muscle strength. So there was a really long and interesting discussion about the results they found. This is a really interesting study to read. So I'm just going to take a couple of quotes out of their discussion because I thought this was really interesting. So we suggest that increasing intra-abdominal pressure during an inspiratory muscle training load might condition the pelvic floor tonic muscle fibers and enhancing the endurance. But also that the quick and forceful contractions needed with IMT can condition the fast twitch muscle fibers of the pelvic floor muscles to respond better. So again, the data suggests that strength gain in respiratory muscles might attenuate an impaired functional capacity and enhance overall functional performance. So again, this was just doing the inspiratory muscle training. So again, we're still not coupling the breathing exercises with pelvic floor muscles, but we're seeing that just simply activating and engaging the diaphragm and inspiratory muscles can have a positive effect on the function of pelvic floor muscles. This was another new study looking at the effects of high intensity inspiratory muscle training done throh telerehab. So this was done virtually. And again, we've got 22 women with stress urinary incontinence randomized to receive either high intensity IMT or sham IMT. The intervention group, well, they both did 2 times 30 breaths, 2 times a day, 7 days a week for 8 weeks. It's just the intervention group did their resistance starting at 60% of their maximum inspiratory pressure. The IMT intensity was progressively adjusted to maintain a rating of 4 to 6 on the modified Borg scale, so the rate of perceived exertion. You're definitely working. They wanted it to reflect the highest tolerable level of perceived respiratory effort. And they had these weekly telerehabilitation sessions that were supervised by a physiotherapist um, to make sure they were adjusting and doing the breathing properly. So basically, the results were they had increased pelvic floor muscle strength, they had increased maximum inspiratory pressure, but there wasn't any statistically significant differences in the urinary symptoms between groups. Okay. The pelvic floor muscle function showed significant improvement in the intervention group. They had increase in peak maximal voluntary contraction, average maximal voluntary contraction, and pelvic floor muscle endurance. So again, really good study. I would say again, there was no link between performing breathing and pelvic floor muscle exercise at the same time, maybe to create a functional coordinated task between the two. So it'll be interesting to start seeing some incorporation of pelvic floor muscle activation during these inspiratory loads to see, does that create a more improvement, especially in some of the urinary symptoms, right? So that translating into function. So again, increased pelvic floor muscle strength is great, but if it doesn't translate into function, meaning reduced symptoms, we're still having a gap there. I thought this was an interesting study. I was looking at, okay, if we know that the pelvic floor muscles are active in the expiratory phase, more so than inspiratory phase, what have we got for expiratory muscle training? Of course, this is a little bit new, but this one came up from March of 2026, so brand new. Role of phonation, so voicing. Okay, so this is this of sounds. When we are speaking, we are having to activate our expiratory muscles, right? So this is going to include our abdominals and our pelvic floor muscles. So they were using EMG activity of the pelvic floor muscles during the production of various sounds. So we've got some vowel sounds, and then we've got the Z sound. So that would be kind of what we call a semi-occluded vocal tract. So there's some pressure to the vocalization. And so the pelvic floor muscle activity increased significantly during phonation. Of course, the Z sound, so you have to work harder with that one, caused higher activation than the more vowel sounds. So again, this is looking at how we're using the pelvic floor muscles in speech, which is a little bit more of an expiratory effort. Okay, so now we're going to kind of reverse it. We were looking at using breathing to affect the pelvic floor. What if we did pelvic floor muscle exercises to impact pulmonary function? So this study is an older study, 2015, but kind of started looking at that reverse role, if you will, and started a few studies looking at the role of including pelvic floor rehab into pulmonary function. So can the pelvic floor muscles improve pulmonary function? Yes, they can. So in this study, 30 females aged 19 to 21 were randomized to a control or an intervention group. The intervention group basically did Kegel exercises again. So that's that lifting of the pelvic floor muscles. They did that 3 times a day for 4 weeks. And by the end of it, the experimental group significantly improved forced vital capacity, forced expiratory volume, so FEV1, peak expiratory rate. Anyway, all those measures had increased because they were having a little bit more pelvic floor muscle contraction. So if we think about that, we know that the pelvic floor is more active on exhale. So if we are breathing out hard, and we have support from above, or sorry, support from below, so the pelvic floor muscles, and usually that feeds over into the deep abdominal muscles, creating that control stability and supporting the abdominal pressures to help exhale the air. Then, in theory, that should produce a better control on your expiratory maneuvers. And that's what this study is kind of demonstrating. Then we can jump forward 10 years and we can look at the effects of expiratory muscle training combined with pelvic floor muscle exercise on pulmonary function in healthy adults. So this is a 2025 study out of Korea looking at the addition of expiratory muscle training and pelvic floor muscle activation versus pulmonary or pelvic floor muscle activation alone in improving pulmonary function. Okay, so we've got 20 individuals doing EMT and PFM, and then we've got 20 individuals doing just pelvic floor muscle activity alone. They were measuring FVC, FEV1, and PEF. And so both of them increased significantly their respiratory measures, although we saw that with those doing EMT, they also had an improvement in FVC. Okay. So would this translate? So this combination of EMT and PFM training can be effective in improving lung function. Would this translate to our populations with lung disease? So these were healthy adults. So that would be something I would think would be kind of our next step. Hey, if we're using this in our respiratory population, does it make a difference, right? Because we know that their airway flow limitations are due to other reasons. All right, so moving on again to the effect of pelvic floor muscle combined with pulmonary rehabilitation training on lung function in elderly patients after surgery for fractures. And so what we've got with this one, both groups underwent routine rehab, which included joint motion training, lower limb muscle strength training, balance training, walking training, daily activities of life. The control group had breathing training, which they described like standard breathing training. This was an interesting article to decipher because it was translated. And so there was a few things that were lost in translation. So the control group had diaphragm breathing and pursed lip breathing, and then the intervention group paired pelvic floor muscle activation with breathing. So basically it was they were lying down and they were working on breathing in and then pursed lip breathing. And then they had facilitated lateral costal breathing. So they had therapists with hands on the side of the ribs and trying to breathe into the ribs to create a better diaphragm, kind of thoracic expansion, and kind of cueing for a relaxation of the pelvic floor. And then we had pursed lip breathing with a pelvic floor muscle contraction. So now we're starting to see finally, or that coordination. So we're starting to see, okay, we're not going to just do breathing by itself. We're going to do the breathing paired with a pelvic floor muscle activation. And so the results were that we had this intervention group had greater improvements in lung function and diaphragm function than the control group after 4 weeks. So again, you can do it on your own, but when we add that all together, we're getting better results overall. So where do we go from here? And this is where I'm hoping we can stimulate some conversation. I touched on this area. We tried to look at the effects of inspiratory muscle training on pelvic floor muscle function. This is back in 2016, so I guess 10 years ago. And it was just kind of a pilot study, myself and a couple of clinicians. Not being from the research world, though, it was a bit of a struggle just trying to, basically, it came about from a clinical question. Well, what if we used inspiratory muscle training in pelvic floor, patients with pelvic floor dysfunction? Where could we go with it? I will tell you, we didn't really come up with a very good answer because as we went through, we had a bunch of difficulties. We were going to use ultrasound. But then we found that we were displacing the probe too much. When you breathe with an inspiratory effort, there's a lot of abdominal movement, which displaces the probe. So it kind of messes up with your ability to assess properly. So I think there's a lot of promise in this area. I think we need to have a better understanding of the factors influencing pelvic floor dysfunction and how breathing could play a role. So if we have someone whose muscles, so we know this happens in pelvic floor, is the muscles are actually too tight. So when we think about that that movement. When you breathe in, then the pelvic floor muscles in theory are supposed to relax and expand. For some individuals, they can't let go of that tension in the pelvic floor. Is that a place where we could be using a low load of inspiratory muscle training to try to facilitate, as that diaphragm's coming down into the abdomen, facilitate that relaxation of the deep abdominal muscles in the pelvic floor? If it's a weak pelvic floor, maybe should we be looking at expiratory muscle training, or do we look at a combination of both so that we're having, again, that whole system working well? Should we be looking more at integrated interventions? Again, that's my bias, where we're pairing the diaphragm and pelvic floor function. They aren't working in silos, so maybe we shouldn't be trying to explore them in silos. Maybe we should be bringing them together. And then maybe this is happening a lot, but are we using pelvic floor muscle exercises in pulmonary rehab, not just to support our patients who are coughing, who are probably likely having a high level of incontinence if they are coughing a lot, but also just to support respiratory function? I have a few pages of references that are available. I don't know, Sabrina, if you guys share the slides or if we'll put that somewhere so that people can look through some of these studies, because I came up with a lot of them, and they're fun. It was fun actually going down this rabbit hole for sure. So yeah.
Thank you,
So, but
Jessica. Yeah, I'm happy to share the slides. I'd certainly love to read some of the papers. As you say, you've done a lot of work for us, so thank you so much. I just I found that so enlightening. And as you say, and as we started at the beginning of this presentation, this is an emerging field of research of which I think there is so much potential. What I really, really liked, and I personally hadn't thought about it, which is perhaps my naivety, but the first thing is you flipped things. So I thought we were going to just be talking about people that have pelvic floor dysfunction or stress incontinence, and can respiratory muscle training help that? But actually, we've got a cohort of patients with respiratory disease who may also have pelvic floor dysfunction, and how the two go hand in hand. That I find fascinating. That
mhm.
I think is certainly an area that I imagine would be really interesting for future research. And the other thing as well, again, perhaps my naivety, is integrating not only IMT but EMT. I understand the synergy and the cylinder that we talk about and the diaphragm, the pelvic floor muscles working together. I thought perhaps it would just be IMT that would create this tightening effect. But actually, as you've shown with the phonation paper, might not be the case.
Yeah, well, I can say the very first time that I grabbed the new EMT device and I went to blow on it, I went, oh, I need to be a little bit more careful with this. And I knew like right away that you need to have pelvic floor support to breathe into, to do expiratory muscle training. Because the danger is if we just set some up with expiratory muscle training and maybe don't include that pelvic floor, is that someone with a weak pelvic floor, lower abdominal muscles, they're supposed to be breathing out that way, but it's
Yeah.
going down. So
Yeah.
it's definitely something that is key. And I think that again, you can then, because you're having the biofeedback of breathing out against something, and that's what happens with that phonation. Oh, now I can feel my pelvic floor a little bit more. So you can kind of like, I like the idea of both IMT and EMT as a biofeedback tool as well. You can I mean, that's what I will use IMT a lot for, the diaphragm is a biofeedback tool. Oh, that's where that muscle is. Now
Mhm.
I can feel it, because these are not muscles we can see
No.
and easily feel.
Mhm.
So that resistance just kind of brings it into the forefront of our brain a little bit. We can be like, oh, I can feel that.
Yeah, no, it's a really nice sort of way of phrasing it that you get biofeedback. People, we often describe, you get a bellyache. People are engaging their diaphragm possibly for the first time. I wonder if in any of the research that you did, which was so substantial, did you see or come across anything to do with prevention? So we talk about the load. I'm thinking
Mm.
perhaps in a cohort of people that might be pregnant, they have a large abdominal load. Is there any research to support prevention that will then using respiratory muscle training, or is that another?
Yeah, so You know what? I didn't take the dive down into and Scott, my colleague in New Zealand, sent me a few articles and I was like, oh, I don't have time to go through that. There's a whole other rabbit hole to be looking at during pregnancy, early postpartum, like those kinds of things. And I just didn't have the capacity to go down that rabbit hole at the same time. So again, I think from this area, there are places that we can be looking at and investigating for sure, because this is a low consequence intervention,
Yeah.
right?
Yeah.
And again, we're just trying to see if we work on one, does it affect the other? So that's where that whole thing is like, well, if these are working together, let's work this to help this, let's work this to help this, right? So yeah.
Yeah, and again, you phrased it so wonderfully. It's a low consequence intervention. We have to be very careful about advocating that certain cohorts of people do respiratory muscle training. But speaking from experience, I mean, I certainly did it when I was pregnant. And if you're sensible, I don't think very much is going to happen any more so than in normal day-to-day life. So,
Yeah, you're exercising a muscle. I mean that is the forefront of this exercise. That's what it's all based on. IMT, EMT is just about, hey, these are also muscles that could probably benefit, as do all of our other muscles from
yeah.
some kind of strength training. Yeah.
Yeah. No, and actually probably a very good time to do it. If anybody else has any questions, please, or any other topics that they think would be interesting for future research, please feel free to put them in the chat or the Q&A. Um, I think you've given everybody a lot of food for thought. Renata's got her hand up. I don't know if you're able to write a question, Renata, to see if she's all right. Maybe it's gone now. There we go. Somebody has written what type of pelvic floor muscle or pelvic muscle exercises are
Yeah.
preferred?
Yeah. So I'm going to just put the caveat in here that I'm not a pelvic floor specialist, right? This is more like me. I'm thinking, okay, what are we like? Breath and the diaphragm are working together. So I'm not going to like to discuss like high level, but I just definitely think that we want to make people aware of when you breathe in, can you feel the pelvic floor muscles relax? That's probably the hardest one, but can they breathe down into the pelvis, relaxing that way? And then as you're breathing out, can you lift up the pelvic floor muscle? So essentially like a Kegel type exercise where we're contracting, squeezing, lifting, oftentimes using that pursed lip exhale will bring that with it. Now, because I'm not necessarily, I don't do pelvic floor internal exams or anything like that. I kind of come at it from the breathing perspective and would work in conjunction with pelvic floor physios. So as a team working together that way. So I'm not going to dive into these are the best ones to use because I think it all depends on if the muscle has been evaluated and it's tight and we need relaxation. Is it weak from a maximal voluntary contraction perspective? Is it weak from a endurance perspective? And I think that's that where do we go from here is let's get a little bit more specific about it because I'm not certain reading through these studies that the problem with doing research on humans is that each human is different for various reasons, so many confounding factors in each human. Okay. And so one of those could be, did we have someone in there that was actually hypertonic and they were really tight? Did we have someone in there that actually had good maximum, like one off one, but their endurance was terrible? And did we have someone else who had good endurance, but terrible maximum one, but they were all included in the same intervention? And maybe that's where we don't, those are kind of three different factors, in my opinion. So again, a little bit more targeted approach.
Hmm. I think, and you've touched on this, I guess this is taking it to the next level, but it just also hones down that idea of looking at the whole patient. We're not just isolated looking, you're a breathing physiotherapist, but it's considering all these other things that might be related and how they can be improved.
Yeah.
So somebody, or there's a few questions. One is, how do you actually coordinate respiratory breathing with pelvic floor exercises? I know some of the papers were perhaps maybe considered substandard from that point of view, and there was holding of breath. How would you
Mhm.
suggest doing that?
Yeah. So it's you're ideally you want to get the basics, right? So you want to have that, right? You want to be able to breathe in and pelvic floor relaxes and breathe out, pelvic floor lifts, contracts. We get that contraction through there. So that's kind of our ideal situation, and then we want to move on to function from there. So again, I'm not going to step on the toes of the pelvic floor physios right now, because there are definitely far more experts in this field than me. But looking then, okay, what happens with different loads, different positions? So we're just really trying to make that functional, and knowing that sometimes we're going to have to breathe in, and actually we really want to increase intra-abdominal pressure. So we are going to have the diaphragm come down because we breathe in and we might do a breath hold. So some loads are high enough that we have to do that. And we want to have the support of the pelvic floor. So yeah, it's really all about kind of working all that together. Lots of pelvic floor courses out there that will talk about it. I know, just jumping ahead to Cindy's other question, she thinks that it's paradoxical breathing or sucking in the abdomen. That's probably a little bit more the hypopressive technique, where they do actually kind of suck in without breathing in. And that's to deal with pelvic organ prolapse. Again, it's as a breathing physio, not my favorite thing to do because it's not the functional movement of how these muscles are working on a regular basis. But
Hmm.
those are like rabbit holes to go down for sure.
Hmm. Really interesting. I think you can see the questions, Jessica. So I
Yeah.
was going to go with the top one, which again is a really interesting one. Is there any link that you could see with overactivation of the pelvic floor in chronic respiratory populations with stress incontinence?
It didn't look like anyone was reporting on that. Like there wasn't internal exams where they were reporting on that overactivation. So that's what we're talking about is that if those pelvic floor muscles are kept really tight and overactive, then you actually have a dysfunction in that as well. And then they have trouble with incontinence and stress urinary incontinence. So meaning that when there is a cough or a force or a jump or something, there's a leakage, right? And there just wasn't, from what I could see, there wasn't, I couldn't see a link with that. So they were just saying that it was pelvic floor dysfunction, but they weren't necessarily bringing it down to, well, it was too tight versus too weak or anything like that. Yeah.
Yeah. Okay. Again, another, as you say, there's obviously this challenge of how you measure that when you're doing the exercises, but
Mhm.
something for the future. And this is an interesting one. Did you, in the extensive research and literature review that you did you come across any papers to do with patients with Parkinson's disease? We know that there is evidence to support, significant evidence to support the use of expiratory muscle training in this patient cohort. And Emma's written that they also often have urinary symptoms such as stress or urgent incontinence.
Yeah,
What?
I didn't go into specific populations so much in urinary incontinence. I mean, the COPD ones kind of came up because I was, I was really looking for, okay, this diaphragm and pelvic floor relationship. I glanced quickly and saw there was one with multiple sclerosis. I have in the past looked at respiratory muscle training, whether IMT or EMT, for people with Parkinson's, but didn't necessarily go down into the next symptom list, right? Which could be urinary incontinence, right? So I didn't go down into that, but it would be, I guess, an interesting population to study. Um, they would likely benefit from from that whole, if that whole canister is, again, anywhere within that whole canister is disrupted, then we can expect that there's going to be problems in other areas. So I personally didn't come across that. Doesn't mean it's not out there.
And I think it may also just be a consideration for future research. As you say, we know that
Exactly.
there is evidence to support, in this example, EMT in Parkinson's disease. But have we asked in the same study whether they've also had a benefit of these other symptoms? Maybe not. So it's just, yeah,
Yeah,
really.
exactly. I mean, you could, you know, in your next study, maybe you're not specifically looking at the pelvic floor muscle function, but you could oh, I'm going to just ask about urinary incontinence. Is that an issue for you? And is it still an issue for you after you've done this, whether it's IMT or EMT? Yeah, for
Yeah.
sure.
Yeah. Really, really interesting. I think that those are our questions. Um, Thank you so much.
Yeah.
Everybody's saying thank you. I found it. Yeah, I was really looking forward to this presentation, and you've done such a nice and thorough review, and it's given, I think, a lot of food for thought for us to go away and both look at and consider for the future. So thank you so much, Jessica.
Yeah. Thanks for
Yeah,
having
thank
me.
you for your time, and I hope you enjoy the rest of your day.
Yes.
A
Thank you very
little bit
much.
earlier than where we are. Thank you.